Since joining PNI, we have developed one of the very few centers for facial nerve disorders in Southern California and on the West Coast. This is an area of patient care that I'm very passionate about, and so I'd like to hopefully provide some insights into the management of facial paralysis and how we can better take care of these patients. I know a lot of these patients are seeing you in urgent cares, in your primary practices, and I'd like to go through some of the things that we can do to help these patients who don't recover completely. And so why is the face important? Well, it defines our identity. It provides both verbal and nonverbal communication. And emotional expression is universal and highly conserved among species. This has been known since the time of Charles Darwin, if not before. And what does this mean when it says it's highly conserved? Well, our survival depends on being able to communicate. And so if you are trying to find a mate, or you're trying to respond to somebody who's just by using your smile or just by blinking and showing that you can communicate with them, if you're unable to do that, the observer may not be able to respond properly and may just walk on and just ignore you, or may get the wrong impression of you. And so being able to communicate emotionally is extremely important and allows us to evolve and to continue through natural selection. And so what are the functional deficits of facial paralysis? Well, this woman here has complete left-sided paralysis. What you can see here in the upper face is she has brow ptosis and a visual field defect from the brow blocking her vision. She's unable to blink effectively. This would lead to dry eye, irritation, epiphora, or chronic tearing. She could potentially develop an exposure keratitis and go blind if not managed properly. Nasal obstruction is commonly seen in these patients, especially in the older ones, because their midface is so heavy and it's no longer being suspended by the ligaments and muscles of the face, and it just collapses and blocks their airway. And in the lower face, obviously we are concerned with the inability to smile, but also eating, drinking, speaking, articulating are all affected. So how do we as observers view the face? Well, this is a study that performed electroretinograms, and they followed people's eyes and they tracked them in the first 3 seconds after seeing images. The bright red is where most of the time was spent by the observer. And so what you'll see here is in the images on the left, in the normal and the repose and smile, that the observer is focusing directly on the central triangle, the area between the eyes, the nose, and the mouth. Now, when you look at the patient on the right, when she's at rest, her face is fairly symmetric. She's young, there's not a lot of inconsistency, and the observer can focus on that triangle. But when she smiles, our observation is distorted, and that central triangle is shifted to the right. And that quick millisecond of movement and the observer's attention being taken away, you can see that you're no longer focusing. The red that we see that was on the other image or on the image above is no longer focusing on the eyes or the mouth properly. And so we know that patients with deformities are considered more disfigured and bothersome by observers just on questionnaires. But we found that the location of disfigurement is very important, and those large central disfigurements are much more bothersome for observers than those that are found laterally on the face or elsewhere. What psychological factors are associated with facial paralysis? Well, there's a significant contribution to social disability and functional impairment from facial paralysis. Patients with facial paralysis complain of social isolation and depressive symptoms in 65%, which is 3 to 5 times our general population. A quick anecdote, actually during COVID, patients with facial paralysis were polled and were actually found to feel a lot better from a quality of life standpoint, because they weren't interacting with people as much, and they were able to block their cameras on Zoom. So it is a very interesting finding, and I think a pandemic will maybe give us some new information on these patients. How's quality of life affected? Well, there's a dramatic impact on patient-reported quality of life. Patients with facial paralysis, when asked on health utility outcome scores, rank themselves below somebody with monocular blindness and on par with end-stage renal disease and HIV. This study is a little outdated, but I think at the time, HIV was still a terminal illness, and end-stage renal disease obviously means you're on dialysis. And so patients are significantly impaired when you think about it. They're willing to sacrifice 8 years of their life with paralysis for a normal face, and they would undergo a procedure with a 21% chance of death just to reverse the paralysis. So a 1 in 5 chance of death just to reverse the paralysis. If you think about how dramatic that is, I think the percentage of patients who die during anesthesia or die during surgery is probably less than 0.01% today. And so that's a significant increase in risk they're willing to take. A large percentage of patients, 20 to 30%, who are deemed cured by their providers, still report subjective symptoms. And these are the patients we'll see in our offices, the ones who have basically been told, okay, you're fine, you're better, it's time to move on with your life, and they still have significant issues. So what are the most common causes of facial paralysis? Well, there's the infectious cause. We're all familiar now with Bell's palsy, which we believe is secondary to a herpes simplex reinfection, Ramsay-Hunt, reactivation of varicella zoster. Otitis media, we do see from time to time, a few times a year, and then Lyme disease, not so much on the West Coast, but commonly more on the East Coast. Penetrating trauma, temporal bone fractures, can also cause acute facial paralysis. Tumors in the middle ear, cholesteatoma, or in the brainstem, as well as tumors on the nerve or metastatic cancer. Skin cancer is a common cause of facial paralysis, or parotid tumors. And then in children, you can see it in congenital syndromes or from birth trauma. So I'll focus primarily on Bell's palsy and Ramsay-Hunt today, as these are the most commonly seen. So Bell's palsy is the most common cause of facial paralysis. 20 to 30 out of 100,000 people are infected. We do believe that there tend to be epidemics of this, so they do come in clusters. And it's believed to be related to the HSV1 reactivation, which causes swelling of the facial nerve. When I describe this to patients, I describe it as the nerve living in the bone behind the ear, which you can see by this arrow. When the nerve is inflamed, it actually expands, but the bone around it doesn't move. So when you think about that, the bone is actually crushing that expanding inflamed nerve, and then downstream activity is shut off. And it's the amount of time that it takes for the nerve to recover, not regenerate, or not regrow, obviously, but to recover and regenerate, is important, because the faster that is achieved, the less likely they'll have long-term side effects. So this is a patient of mine who presented very acutely right after she developed Bell's palsy. You can see here, when you look at her facial movements, the left side of her face is not moving as well as the right side, or at all. And she can't close her eye. When she tries to, you can still see her pupil, which shows you that her eye is very high at risk for injury. These patients will typically present with a prodrome. They'll have the burning pain in or behind the ear, reduced taste sensation, reduced tear production. And then they'll develop acute paralysis within 24 to 72 hours. They'll have a sensitivity to sound or hyperacusis. And in most patients, they will recover within a few weeks to months. If they recover within 1 to 2 weeks with the steroids and antivirals, they typically don't have any long-term sequelae, but about 15% of them will take more than 2 to 3 months to recover, and will have what we call synkinesis, which I'll discuss in a moment. The standard treatment for these patients within 72 hours onset is to initiate a high prednisone taper. We mentioned it earlier with Dr. Anwar when treating patients with anosmia. I'm sure Dr. Volker, one of the other doctors, will mention it with acute sensory neural hearing loss. But facial paralysis and Bell's palsy are no different. You want to put them on a 60 milligram prednisone taper for 5 days, and then taper for 5 days, so 10 days total. You would like to initiate antiviral therapy with Valtrex within 72 hours, or acyclovir. And this is to treat the postherpetic neuralgia after 72 hours. Data doesn't really support it. You do, first and foremost, want to mention eye protection. So artificial tears, lubrication, a moisture chamber, saran wrap, taping it shut, whatever you can, prevent that eye from getting injured, as it can be a nightmare to manage later on. And if patients don't recover within 3 months or 6 months, you do want to perform imaging, because at that point, even if they haven't had any yet, you do need to start thinking that there could be another cause of this, and you have to make sure there's no tumor there. Now, as I mentioned, 10 to 15% of patients will develop synkinesis. And sorry. On a case-by-case basis, if patients don't recover after a month, I will usually get them on a second round of steroids. I don't typically put them on a second round of antivirals, although if it's a multiple cranial neuropathy, and if you feel like it's helpful, you can do that. But if it's primarily a facial nerve issue, a second round of steroids for 10 or 14 days usually isn't a bad idea if they haven't had significant recovery. Ramsay-Hunt syndrome, we'll briefly talk about this. It's due to the varicella zoster virus reactivation. These patients are typically more sick than your typical Bell's palsy patients. Bell's palsy, by definition, should not cause hearing loss. It could not cause vertigo, but Ramsay-Hunt will. or it can. And it can also cause other cranial neuropathies. I've seen patients with vocal cord paralysis, swallowing issues. I've seen patients with tongue issues, hypoglossal nerve. And so it is a much more severe illness. And that being said, it also is less likely to recover completely. And so patients who develop Ramsay-Hunt should know, or when I see them, I will tell them that the likelihood of a complete recovery is not that high. The treatment is essentially the same. So this is a patient, the one I showed you earlier. So you can see here, she had a complete recovery. She started regenerating within 2 to 3 weeks. And so before and after, she's able to generate complete eye closure, which she was not before, and also able to have a full smile. Now, I mentioned the word synkinesis several times. What is that? Well, synkinesis is the miswiring of nerves after trauma or nerve injury, and it results in involuntary muscular movement accompanying voluntary movements. And so if this is a beautiful diagram of what the facial nerve looks like before someone has facial paralysis, this is how I typically describe the nerve afterwards, or what it feels like to patients. And we'll go through what this means. So these are patients with post-recovery synkinesis. As you can see here, and they've all been told by their doctors that they're fine and they're recovering. And so for better or worse, they show up in our office, and we really do want to ask, are they really cured? Well, I would very, very strongly say no. The person on the right, every time she smiles, her whole face contorts, the right eye completely shuts, and you can see in the middle as well. The person in the middle has a left-sided facial paralysis. When she tries to smile as much as she can, she's unable to. And then similarly, the patient all the way on the right, when she tries to smile, her right eye closes, her right corner of her mouth doesn't lift as much as it does. Now, it does move a little bit, but again, we live in a very dynamic world, and this inability to move and convey emotion is very troublesome for these patients. So some of the examples here, you can see at rest, this patient on the right, she has increased tone. What does that mean? It means that her muscles are always on, they're active. You can see how deep that creases in her nasolabial sulcus from the nose down to the corner of her mouth. This is her at rest. With just a gentle smile, her right eye starts activating and shutting down, and then when she makes a big smile, the whole right side of her face contorts. And what this is really meaning is that the involuntary muscles are moving. On the left side of her face, she makes a beautiful smile. When she smiles, her eye doesn't close that much, her cheeks generate upward trajectory, and her neck doesn't do anything. But on the right side, her neck is pulling down, her muscles are acting completely pulling and pushing against each other, or opposing each other, and then the muscles around the eye are completely closing as well. And so what do we do to treat these patients? Well, we have multiple options. We can do physical therapy or facial retraining. There are several experts in the area that can offer this. They're usually physical therapists or occupational therapists. We can perform directed chemodenervation. Sorry, I shouldn't say Botox there. We should say chemodenervation therapy. Xeomin, Botox, Dysport, any of these medications can be approved by insurance for this. And then in very selective cases, there are surgeries that we can offer. However, these are for the most severe patients. And where can we provide this treatment? Well, and this is not just done in our office. Neurologists and other plastic surgeons can offer this as well. We try to treat areas to create symmetry. So we can treat the frontalis muscle or the forehead on both sides, the corrugators, the orbicularis oculi of the affected side to prevent it from shutting. We can treat the chin, the mentalis, depressor muscles, and the neck, the platysma. The area that we do not want to treat is in the midface, so I typically don't treat anywhere from below the orbital rim to the corner of the mouth, as the product that we use is a liquid, and it's very easy for that liquid to spread, and then you would ultimately cause a paralysis. Now, I know that there are neurologists who do EMG and neurosurgeons who are using EMG, and they're able to do very precise injections, especially for patients who have hemifacial spasm. I have just not found that to be as useful in these synkinetic patients. This is an example of a patient. You can see here he was treated with chemodenervation on the right and the left, and this is an example of showing you where he was treated. So he got his treatments into the left eye to help it from closing as much, and then he also was treated on the contralateral face to help improve symmetry. So we'll treat both sides of the face, not just the affected side. Now, this is a woman who I showed you a few slides ago with a severe synkinesis. She actually underwent surgery. Her synkinesis was so severe that we actually decided to go in and cut the aberrant nerves that were functioning improperly. And so this is a very sophisticated and nerve-wracking surgery, honestly, going in. I tout myself as a facial nerve repairing surgeon, not a facial nerve cutting surgeon, but in some cases you have to do that. And so here you can see before and after photos of her. While she still has some tension on the right midface, you can see that her right eye is much more open after surgery. Her neck is much more relaxed. Her lower lip is no longer being pulled up at rest. And then when she smiles, she's also able to have a much more relaxed face. And so this was essentially a surgery where we went in, we mapped out all of her nerves. We stimulated them intraoperatively using a nerve stimulator and found which ones were acting properly. And when I say properly, I mean we know as surgeons, we know which nerves are going to have the corner of the mouth elevate, and we know which ones are going to have them depress. And so when we stimulate the nerve and it acts to pull the mouth down when we know it should pull up, we tag those. And as long as we have enough nerve branches that are doing the right thing, we can go ahead and safely cut the ones that aren't. And so this is a close-up of her mouth. It's not perfect, but just allowing her to be able to show one or two more teeth on a smile made a huge impact in her quality of life. So when we talk about patients with chronic paralysis, we do have some other options. These are the more sophisticated surgeries, the microvascular techniques that Dr. Griffiths was talking about. We can use nerve transfers from the hypoglossal nerve, which controls the tongue, or the masseter nerve, which controls the masseter muscle. And so these are just some dissection anatomic examples of showing how we dissect this nerve. And this is a before and after of a patient. She underwent radical parotidectomy and at the time was not prepared for a nerve repair by her primary surgeon, which can happen. And then she presented to us. We performed a masseter nerve transfer. And then Dr. Kraus from the neuro-ophthalmology group did eyelid reconstruction. And you can see she has an incredible result. She's able to smile by biting down and generate that smile. This is a gentleman who had a radical parotidectomy as well. We performed an interposition graft where we harvested a graft from his leg, a nerve graft from his leg, and put it between his proximal and distal facial nerve stumps, as well as gave him the masseter nerve, and he's able to, this is him 6 months after surgery. Some other techniques we can use where we would, in combination with Dr. Volker, where we would trace out the facial nerve as it goes into the skull base, and we can drop it down into the neck, and we're able to show, by moving your tongue, we're able to have patients have symmetry at rest, and then generate a smile as well by moving the tongue. The last few photos are where we do combination surgeries, where we do the nerve to the masseter as well as the hypoglossal nerve. This was a young girl who had a brain tumor. She presented 1 year after complete paralysis, and we were able to, within 4 months, have her generate a beautiful smile by biting down and moving her tongue. Now, we don't always do nerve grafts. This is a very patient-specific type of procedure, and so we have some patients who decide they don't want to wait the 3 to 4 months for the recovery. This was a relatively young at heart woman from Palm Springs who was going to be driving 2 to 3 hours for every post-op visit, and she was, after 1 year of being paralyzed, was ready to move on with her life. So she elected to have a muscle transfer surgery. And so this is a 6-week post-op photo of her where we took the temporalis tendon transfer. We made an incision in her left nasolabial fold. We tunneled to the coronoid process and brought this tendon down. And so when she bites down, she's able to smile there. And she's very pleased with that. And so these are surgeries that there's not a one-size-fits-all. And this is a young girl. This is probably the most sophisticated procedure we do, where we actually transplant muscle from another part of their body with an artery, a vein, and a nerve. She was born with congenital paralysis of unknown origin. You can see here her left eye is larger, her midface doesn't elevate, and her nose is collapsed. So we transplanted a muscle from her thigh, the gracilis muscle, with an artery and vein, and we were able to then use the nerve from her masseter to help generate her smile. And this is, again, for patients with chronic facial paralysis. She's 1 year post-op here. So in summary, Bell's palsy is the most common cause of facial paralysis. For the primary care physicians and neurologists in the audience, if anyone has delayed recovery greater than 2 to 3 months, they can develop chronic synkinesis. which may also benefit from medical or surgical treatment in certain patients. Chronic facial paralysis, that being greater than 12 to 18 months, does require surgical intervention. In the acute phase of facial paralysis, in which it's not medically managed, nerve transfers can be performed. And in the chronic phase, patients may require to undergo regional or distant muscle transfers for reanimation. Facial paralysis does not just affect adults, it can affect children as well. And so this is a young boy who had a temporal bone fracture, and we were able to, with the help of Dr. Volker, reduce the fracture on the bone and also did a nerve transfer on this patient. And so you can see here we're able to regain his symmetry. But thank you very much for your time and for listening.
So, Dr. Kochhar, any thoughts what your approach is with a patient who gets recurrent facial nerve paralysis?
Like a recurrent Bell's palsy? So it's very, very, very rare. In my practice, it seems to be fairly common, but it's exceptionally rare. First thing I would do, if it's on the same side, is I would definitely recommend re-imaging the patient. I would say that, because it's so rare, you do want to make sure that there is not a tumor. The imaging I would recommend for that patient would not just be an MRI of the face, but I would also get an MRI of the brain and look at the internal auditory canal. Bless you. Just because you want to make sure you're not missing something along the facial nerve at any point. If that was negative and the patient is otherwise healthy, I think repeating the steroids and antivirals are key. And likewise, if it's bilateral, I think you're less likely to have or if it's a contralateral side, a new facial paralysis on the other side, it's less likely that it's a tumor. But I would probably still image them just to be safe. There are very, very few and rare syndromes that can cause recurrent facial paralysis, but I do have a couple patients that have had it for the third or fourth time and fairly young. So it can be pretty debilitating for those patients.
I'm not even sure how to ask this, but when that person had congenital, nerve paralysis, I guess you figured it was peripheral at some point through an EMG. Okay. What point do you know where to, transplant it? How do you, how far back does it go where it could actually work? How did you figure that out?
You mean
as far as the nerve transplant that got her face to work again?
Well, that patient with the congenital, we actually took the muscle from her thigh. So we essentially recreate the function of all of her midfacial muscles. And so in chronic paralysis greater 12 or 18 months, the muscles have atrophied because they're no longer getting stimulation. So in that patient, in that young girl, she may have had very, very small zygomatic major minor muscles, but they weren't functioning. So we recreated. We basically replaced those muscles using the transfer.
My question was more, how'd you know at what point to attach the nerve it would work again? Because it was a nerve.
Well, we didn't use the facial nerve this time. In that case, we used the masseter nerve. Oh. And so her facial nerve is not functioning. But yeah, exactly. That's a good question. Yeah, sorry about that. Yeah.
When we do see patients and, 2 to 3 months, or when do you feel that a patient we were talking about a surgery, you put acute phase. What does that mean?
So that
Where's the chronic phase?
So in the if you know that the nerve is injured. So sorry, so if you know the nerve is injured, if it's a patient with Bell's palsy, they would not be a surgical candidate. But if you know a patient has had temporal bone fracture, if a patient has had a previous surgery, and we know the nerve is cut or we have a high suspicion, we would want to do a nerve transfer within the first 12 months if we think that the nerve, if they're still considered a complete or near complete paralysis in that case.
Okay, thanks.
All right, thank you guys very much.
All right, so we have a scheduled break now, so please visit with some of the sponsors outside. There is you'll be able to see the balloon that is used for eustachian tube dilation, and also there's an implant for nasal valve dysfunction. One side note is the awareness of options for patients. When we were looking to recruit Dr. Kochhar, we called a couple of our neurosurgeons and neurologists in the community, and we asked, what do you do with patients that have a persistent facial nerve paralysis? And they didn't know. They said, well, there's really nothing you can do. Well, today there is, and now you are aware that when you do have those patients, and they may be in your practice, and now you know that you have an option for them to get rehabilitated and get their facial function and movement back. So that's fantastic. Thank you. Let's take a 5-minute break, and then we'll start up after that.